I would just like to introduce myself. I'm one of the editors-in-chief of ACNR, along with Dr. Todd Hardy in Australia. I've been doing it for almost 10 years and he's been doing it for much longer. And ACNR was set up by Roger Barker many moons ago. And really our goal is to provide people with bite-sized, really useful clinical information. And I'm very excited. This is my first ever podcast, and my subjective person I am very happy to be talking to is Dr. Orlando Swayne, who is a consultant neurologist at the National Hospital for Neurology and Neurosurgery, and also the author of the beautiful book, How to Use a Fork. So this is a book which I've treasured reading over the last few months, and it's been with me across Europe as I read bit by bit. But I have to say, it's a really beautiful exploration of the underpinnings of the philosophy of neurorehabilitation with illustrations about patients. And we will be reviewing it in the journal. So this is more of an interview, getting to know the background of the book. So thank you so much, Orlando.
Well, thank you for asking me. It's lovely to be on a podcast for ACNR. I'm a regular reader, so it's nice to be on your podcast. Thank you.
So I really enjoyed the book, and I feel that it was a very interesting way to communicate with both other neurologists and other doctors, but also number one patient. Often the explanations that you give and the patients you describe are people that we will all meet in our clinical practice. And I just wonder, what was the sort of spark that made you think I'm going to write a book about this?
Well, I've been doing neurorehab for a similar length of time as you, I would say, Anne. So for both of us, that's turning into quite a long time now. And I think one of the joys of it, obviously, is the patient stories, the humans, the people you meet along the way, and the privilege we have in our line of work of doing inpatient rehab, which I know you do as well, is that we get to know them quite well. We have the chance to actually spend time with them over maybe, in my case, maybe 4 months at a time would be not unusual, sometimes even longer. So you kind of get to know these patients very well, and actually have the chance to follow them along their journey for a good chunk of it, and then follow them up later. So in some ways, it's quite an unusual privilege to have that sort of time with the patient, and in such intensity, you might say. So I think that's one of the things I love about the job, and I think it's quite hard to communicate that. What's interesting about that, and what's fascinating to me about having that degree of exposure to people. So I just thought it really lends itself to storytelling. And the other thing is, I think people don't really know what we do in this line of work. Even friends and family of mine. One of the fun things about writing this book has been, I've had kind of aunts come and say, I had no idea what you did. Yeah, it's nice to know kind of actually what you do day to day and what that involves. And actually, even, family members don't know that stuff. So it's quite hard to communicate. So I thought it was an opportunity to describe this process, which I think is really quite a special process that we're involved in. And actually, it does lend itself quite well to that sort of storytelling over a longer period. And within the space of the book, you have the time and the space to do that, I hope, properly. I suppose the other motivating factor for me, apart from the fact that I enjoy storytelling, is that it's frustrating as well. So as you and I will both know, we see the patients who get that intense input, right? So, but for everyone who does get that intense input, there's several who don't. And because, as we know, in this country and elsewhere, availability rehab is so patchy and has got worse over the years in many ways, although people will tell you it hasn't, but it has. That actually it's frustrating because, you can see that what we're doing with patients, some of whom make amazing recoveries, others whom don't, to be clear. Of course, we're all familiar with people who don't improve, or don't improve as much as we would like. But actually, it's the ones we see in clinic in other contexts, and we look at them, and I look at them and I think, you're maybe 5 years after a stroke, for example, and you clearly didn't have that input that you needed at that time. And here we are with all these complications and all this wasted time. And, they've been living perhaps a much less fulfilling life as a result of not having had that opportunity. So that's one of the frustrations that I sort of wanted to address in the book, because, during the time I've been doing this, or but since I became a doctor rather than a medical student, I suppose, a few things have changed. On the one hand, our understanding of how people recover has improved, so that the science has got better. We understand more about what's happening in the brain and what the potential can be in some patients for improvement. But at the same time, actually the access to it has reduced, and then particularly in the community. So, okay, yes, there are more inpatient rehab units than there used to be that time ago, but if you look at the community teams, they're all very degraded. That they're all being decimated by austerity. And you and I both, I won't quote numbers at you, but we know that many teams have very, very few therapists. Once you're out of hospital, a lot of patients are not getting the input that they really should, that they really need. So while the knowledge has got more, and the incidence of stroke and brain injury is increased and is increasing with an aging population, actually the availability has gone down. So there's this sort of increasing mismatch between what people should be having and what they are having. So that gap is very frustrating, obviously for the patients most of all. So that was one of the things that motivated me to try and highlight that gap, and to make a bit of a song and dance as much as I'm able to about what can be done in the right circumstances and what we should be doing more of. So that was one of the things that was really driving me to do it.
I loved the way that that does very clearly come across, but there were multiple layers to the book, which I felt were very valuable and very well synthesized, because you also really went back to first principles and evidence. And I think sometimes patients ask a lot about new technology, and really it's so helpful to have the explanations that you provide, and I will be plagiarizing them in my family
Feel
discussions,
free.
about the more abstract symptoms like neglect or, inattention, and also sort of apraxia, things that are difficult, because I suppose everybody thinks about robotic exoskeletons and getting back to walking, but really that ultimately doesn't always bode well for independence in the way that focusing on other areas do, and actually understanding the first principles and working on those is really the heart of neurorehabilitation, and not necessarily super technological. And I found that it was very, very helpful to have all of those layers, from the cells to the person to the overarching aspects. That's very nicely presented in your book. But how did you manage to do that? Because there are so many different layers.
But thank you for your kind remarks, first of all. I think, as you say, the underlying principles are very important, and patients and their families will often come to you and ask about tech. People love tech because people see technology as being something which makes you better, which in many cases it can do, but as you say, it's no substitute for the fundamental components of rehab, which is really MDT therapy input in a particular setting. So tech can't replace that. I mean, it can replace some aspects of it. So if you go to China, for example, they have these hospitals where they have hundreds of these robots. That you have patients sitting in rows with robots doing kind of intensive upper limb work, for example, and clearly there's definite benefit to that. And I wish we had some of that, but it doesn't replace a skilled therapist, and it doesn't replace an MDT. But I think in terms of how you convey that, it's quite hard. I think it's all I can say. I mean, it took a lot of planning, and there are layers to it, as you say. It just takes a lot of careful structuring, really, to do that. I think that the patient stories are very helpful. So, because if you think of a patient who you followed and who you know well, their story tends to convey or say something interesting about several aspects of this whole process, right? So a patient may have cognitive issues, they may have family issues and psychosocial issues that are feeding into their recovery. They may have the obvious medical stuff going on as well. So all patients have these layers within their story. So actually, once you start writing in detail about patients, these layers kind of appear anyway. So they're all there within the patients we work with every day. But it's just a question of trying to convey them and trying to separate them out in a way that isn't overwhelming for the reader. I mean, you don't want to. It has to be readable. You can't overwhelm someone with too much technical information, or it has to be reasonably accessible, right? So I guess that was the skill. Perhaps that's the tricky bit, is trying to convey something that's really quite complicated in a way that you're not hopefully going to lose the reader by overwhelming them. So as to how you do that, I couldn't tell you.
And how did you involve the patients? Did you tell them I'm writing a book and would you like to be in it, or were they amalgamations of different people, or
Yeah, it's a
how?
mixture of those two. A handful of the patients are very directly represented, and for those, I've got written permission from them to use their stories. But even for them, I've changed some basic demographics, obviously apart from name, but I might have changed one or two other things just so they're not readily identifiable by their family or something like that. But they've given me express permission for the others. So I would say about six of the patients that applies to, and then for the others, as you say, that many of them are amalgams or composites of several patients, and it could be maybe 4 or 5 patients, and that's useful as a kind of writing device because not only does it sort of make the consent issue moot because you're not a real person, it's an amalgam, but actually also it allows you to bring in elements of things that you're wanting to discuss or things that you think are interesting you can bring in from other patients you've worked with. So it's quite useful in that sense and allowing you to talk about the things you want to talk about. Yeah, but it's a real mixture, and obviously you have to be so careful, and I hope I know I've been very careful about that, and clearly the text has been legally vetted several times by the publisher, so I hope that that's been successful.
And have you maintained a relationship? Because I've spoken to Dr. Leshner when he wrote his one of his books on sleep, and that was a written interview for ACNR. But you develop a different relationship with patients if you're looking into their story, sort of their overarching story. So has that been an enjoyable part of this process,
Yeah,
or?
very much so. I think for some of those patients I mentioned who are direct representations, obviously I've been in touch with them as part of the writing process and that's an opportunity to actually follow patients up in a way that we don't normally have the ability to. So because of the constraints of working in the NHS and any healthcare system, really, you tend to see people for a limited amount of time. And there is a point where you discharge them because you just can't keep everyone on the books. So but some of the people I'm writing about, I may not, it may have been quite a few years since I worked with them. So it's a really nice opportunity to actually catch up with them. And some of them, I've been around to their, been around to their house. You don't know, well, I don't normally do that as part of my clinical service, that's for sure. That
Only on home visits.
yeah, one of our consultant colleagues there, who you'll be familiar to, you, and actually did used to do that, but he's retired now. But no, it's not something we normally do. So, but even just doing a Zoom or phone call or whatever, it's really nice. And also, you have the space to talk about stuff that you just don't have time to in a normal appointment. To hear a bit more about their lives and what they're getting up to now, and that can be both positive and negative. You actually find out some aspects, of course, haven't gone well, and people are still struggling with things, and that's useful to know that as well as the things that actually they have solved. And the other interesting thing is that sometimes you find that they're very different from they were when you last saw them. And actually, that's one of the main theses of the book, as you know, is that recovery continues. Yeah, it doesn't just stop. We were all taught in medical school that after a stroke, for example, there's a certain degree of recovery. Then certainly by 6 months, that's kind of it in terms of what happens in the brain. But it's just obviously not true. And I think once you start following patients up over an even longer period of time, you start to appreciate that even more. The changes, even over like a 1, 2, 3, 4 years down the line, become more apparent. So I think having the opportunity to go back and get in touch with these patients has been really affirming for me in that way as well.
And then just the process of writing itself, we're neurologists, we're very clinical, we're used to writing very factual, objective documents. How did you make the switch into a more lyrical sort of writing? And had you been doing that before this book, or?
Oh, that's an interesting question. I've always loved a rather sort of, as you call it, lyrical way of writing. For me, that's a very enjoyable thing to do. I think, as you say, in our clinical lives, we don't really have the opportunity to do that. And clearly, as the demands on our time get greater and greater, there's less time for the kind of the traditional long neurology letter. I'm sure you'll remember that. When we first went to Queen's Square as trainees, for example, you'd come across this sort of 4 or 5 page clinic letters, and these, particularly the discharge summaries. I mean, sometimes they'd be up to 20 pages long. Unfortunately, people just haven't got the time to do that anymore. I mean, in some ways, it's a good thing. Who really wants to read a 20-page discharge summary? Let's be honest. Um, but I would say that my way of writing has always been a little bit like that, and I'm sure that in the days of kind of old-fashioned medical secretaries, probably they were cursing me as I waxed lyrical a little bit too much in my clinic letters. So, but as you know, that's changing very much, and now with people using ambient AI, and the letters become more kind of like bullet points, So, but I think something gets lost in that approach, and I think just the demands of time. Sometimes you have to be very succinct in the way you represent information. But actually, if you look at some of these older clinic letters, it's interesting. You do get a sense, and I'm talking about from other people, not myself, just some of the older consultants who tend to write in that way. You do get more of a sense of the patient, and if
Yeah.
it's someone you've not met before, and they come into your clinic and you read the letter, and if it's that kind of letter, you sort of get a feeling for them in a way that you obviously don't with a bullet point. And if you think about some of the original neurologists who write, the obvious example being Oliver Sacks, of course
Yeah.
he would have written his letters that way to start with anyway. So I think maybe a more lyrical approach or a more prose centered approach does lend itself to that sort of way of thinking as well.
And why do you think neurologists are so good at writing books? There's you and there's Dr. Leshner, as I've mentioned, and there's Jules Montague and Suzanne Sullivan. What is it, do you think, about neurologists and writing that is so closely linked? Because it's not so prevalent in other specialties, although I can think of one obstetrician who's very famous later.
Um, yeah, I think that's hard to say. I mean, look, all specialties have their stereotypes, don't they, and their cliches. So
Yeah.
the neurologist is the kind of chin scratching, bow tie wearing pontificator who kind of the general medical, God forbid, the surgeon will slightly roll their eyes at in the way that they talk about patients. But actually, I think there is something about the way we have to approach patients, which lends itself to that kind of way of thinking. I'd say it's a way of thinking more than a way of writing. I think when we, as neurologists, meet patients, we're doing a sort of assessment which includes everything, and obviously this applies to other specialties to some extent as well. For example, psychiatry obviously has to have that approach. But if a patient walks into the room, as you know, we're sort of assessing everything about them from the minute they go in they come in the door. The observational skills are so important, and I think those clinical observational skills are particularly important in neurology. I would say perhaps more than some other specialties, not more than all of them, obviously, but it is particularly important. Those clues from the movement, from the way people talk, everything. So I think you have to be observing the whole time as a neurologist, and that does lend itself to that kind of approach of thinking and writing, I think.
And did you have a writing practice? Get up at 8 in the
Oh, I
morning,
see. Like a daily
50
routine. Yeah, I did actually. So I was lucky to be able to take 6 months off my main clinical job to write this book, which is a luxury not everyone gets. It's very rare to have that luxury, and so that was fabulous. That was life changing, frankly, because anyone who works in a consultant job knows, you've been on a treadmill for a number of years, and actually to step off it for 6 months is life changing, because when you come back to what you're doing, you have a whole different perspective to it. So yes, my routine, I was very. I think the advantage of being a doctor, as we all know, is you have to be pretty disciplined through training and in consultant work. You have to be pretty disciplined with your time. So I think that's helpful because when I speak to other non-fiction writers, some of them said, "Well, 6 months, really? That seems quite quick." But actually, if you only have that time to do it, because you have to go back to a full-time, pretty full-on job, there's just no choice. So I'd go. I started at 7, in the morning, and I would do 4 hours straight, and then pootle about for a bit, and then do another 2 hours in the afternoon, and then I think 6 hours a day is enough of intense
Yeah, I'm sure
brain work.
anyone would say that.
Yeah, so actually that was really nice. It meant that I was actually, by the time my children coming home from school, I'm like, I went from being the dad who's back late and never around, to the dad who's like a bit needy. They come out of school, like, "Oh, hello, I'm grateful to see them." So, what's happened to you? Say, "Oh God, him again." So, but no, it was nice to be much more around. So it gave me that luxury of spending a bit more time at home, which was worth an awful lot. I got to know
Um,
my local yoga class, so that was fun.
oh, wow.
Yeah, yeah. I got to go to the kind of basically old people's remedial yoga class around the corner, which was really quite fun, which was my level. So that was just well.
Yeah, mine too. So, yes, so I think that it also struck me the way you could thread a theme through a chapter. So you were talking about a patient called Alexander learning how to cut a sausage, but you then use the same sort of, description for a postsynaptic membrane when you're talking about. So things like that. how does it feel whenever you feel that it's sort of maybe quite neatly threading together? That must have taken quite a lot of creative thought, and it's really satisfying as a reader to have that all marrying up.
Well, it's great to know that it's satisfying as a reader, obviously, but yeah, I think I like to teach, so, I've rather reduced the teaching aspect of my role now actually, which is sort of a shame just because the clinical bits become busier. But I really enjoy teaching medical students, and a lot of teaching is about metaphors and about representing something that's quite complicated, but in a way that's not only understandable because these are all bright people, right? But in a way that's kind of memorable, you know. So, and just takes a lot of thinking about, and yeah, that takes quite a lot of work to do that well. But I think it's a similar process to teaching. I think if you can do it in that context, then you can probably do it in a written form.
And then just coming along to teaching, because I know that we're all, as a group of specialists, looking at the evolution of rehabilitation and the role of neurologists
Yes.
in neurorehabilitation. And so a few sort of thoughts about that. And first of all, I get to teach undergrads for maybe a morning, half a morning. That's what their whole allocation is for neurorehabilitation. And, I just found your book so helpful because I thought this is something that medical should have to read, because I feel like there are so many important themes that are impossible for me to teach in a morning, but are hugely relevant. Doesn't matter what specialty you go into, you will meet a patient who's had a stroke or an injury of some sort, a brain injury of some sort. They may not, that might not be the reason why they're seeing you as a specialist, but from pediatrics the whole way through to geriatrics, this is really, really important. So I thought, what do you think about the future of training in neurorehabilitation? And I know that I'm not asking you for the answers, but I just think it is such an educational book. Clearly you're teaching through the medium of this book, but how should we try and do this better or differently?
I mean, first of all, if you want to make it put on the syllabus as required reading for medical students, feel
Yeah,
free. I'm sure
I would
I'm
like
sure
to. Yes, I
I'm
will.
sure the publisher would be very
Yeah,
happy with that outcome. But
yeah.
seriously, I think, I mean, the role of neurology and neuroscience in rehabilitation is something I feel very strongly about. I think the direction of travel seems to be that particularly neurology trainees have less exposure to rehab, I think, than they used to. And with the competition from all the other subspecialties, of course, you have to cover everything. But it sort of does tend to be squeezed out, and actually, trainees when they first come through for training, you sort of see in their eyes that they're thinking, "Oh, rehab, really?" I'd rather be doing kind of cognitive or movement disorders or something, and it's not seen as a very sexy specialty. But actually, of course, if you think ahead to what these trainees are going to be doing in their clinics, once they're general neurologists, assuming they're doing any kind of general neurology clinic at all, which is most people, then they're going to be seeing patients with chronic neurodisability, all their MS patients, all their chronic stroke patients with seizures, all their PD patients. These are people with chronic neurodisability. And actually, to understand how to analyze what's often complicated interacting neurodisability is really important. Even if you are a movement disorder doctor or a headache doctor or whatever, you're going to see these patients. They'll come through your clinic. So rehab is, I think, as a training, is very good for that because it teaches you to analyze complex neurodisability. I think with respect to, I think you're asking also about the role of neurology specifically in rehab. This is something I feel strongly about. And again, rehabilitation medicine, it brings an awful lot to rehab. It's absolutely essential. It's a relatively new specialty, of course. It's developing now, and it brings an enormous amount to what we all do, and some unique skills that only they would have. But it can't be the only thing. You cannot have neuro rehabilitation without the neuro bit. So the idea that you can somehow remove the neurologist or the neuroscience trained doctor or consultant from the neuro rehab process is clearly nonsense because, as I just explained, these patients have complicated interacting neurological problems, which you have to understand the pathophysiology of in order to treat them properly. So it's not enough to take a complicated patient and say, right, I'm going to chuck this process at them, and we're going to iteratively apply this process of goal setting and therapy input. That's obviously a big part of it, but it's not enough to do that without having an understanding of what impairments are and how they interact. And that's where the neuro bit comes in. I would argue you can't do it successfully if you remove that element. So I'm very lucky where I work. We have amazing rehabilitation medicine consultants who are fabulous, and we have neuropsychiatry as well, also essential, and we have the whole MDT. So for us, we've got all three of us. We've got rehab medicine, we've got neurology, and we've got neuropsychiatry, and that's the golden setup from my perspective, as far as I'm concerned. We're lucky because we have the resource to do that, but I would argue that you have to have the neurology input. You can't manage without it.
Yeah, I think as on a more remote unit, I think I've been hopefully useful to my colleagues in really helping them to understand the disease and really making sure that the diagnosis is right. And also if the clinical picture changes, I might understand the underlying condition well enough to know whether that's in keeping with what we were expecting or not. And I think I have to say it's a beautiful specialty to be a part of because and as you very much strongly emphasized throughout the book, it's a multidisciplinary specialty and we do it as a team. We work together and we communicate as a team. And often when I see people beginning to walk again, which is one of the most lovely things, because in neurology, recovery isn't always common in any specialty. The therapists really do that and we're just part of it, but we are hopefully, and I feel that we are very important in explaining and continually educating and just coordinating and helping with prognosis. But I also feel that your book will be very useful to me, having done this for many years
Oh, well, that's nice to say.
already. But just, we always, sometimes I feel that I explain things I get my patterns of explaining, and I think it's helpful for us all to have different ways of explaining things and also reminding us how complex the brain is and how complex neuroplasticity is. It's absolutely fascinating. And it's, as Diane Playford calls it, the black box of neuro rehab. We don't know which component of the neuro rehab is the magical bit. It's all of it, really. So I would say thank you for that. And it did strike me that you're the son of a composer and you mentioned a scene where he has his papers on the floor in the attic. And in my mind, I was thinking maybe that's how you got all the different threads together and together to make it work very well. But it felt beautifully orchestrated.
Thank you, Anne.
And
Thank you so much.
a very lovely book. And would you like the listeners who are often general neurologists or registrars, really what is so amazing about neurorehabilitation?
I think it's a specialty where you get to work closely with amazing colleagues, and as I mentioned, you get to spend time with patients in a way that you don't normally in other specialties. So I think it's that combination of working closely with really amazing colleagues and the time you get to spend with the patients. I think it's a really fulfilling specialty, as you say. That I'd recommend it to anyone, obviously.
Thank you. Thanks very much.
And thank you so much.
Thanks for listening. If you'd like to discuss this or any other neuro topics, do come and join us in our online community. You'll find us at forums.acnr.co.uk. Hopefully we'll see you there.